Hello everyone. So now we are going to see about the hospital-acquired infection, which is the next one is surgical site infection, which we call it as SSI. So these infections majorly develop at the surgical site within the 30 days of surgery, or might be in major surgeries within 90 days of surgery. So the types of SSI would be superficial, deep, and organic. Superficial, which occurs on the subcutaneous tissue and the skin, and deep is that in the muscle and muscle fascia. And organic would be into the viscera, organ like liver, kidney, peritoneal cavity, pleural cavity, etc. So the major risk factors for developing SSI would be geriatrics, malnourished, diabetes mellitus, immunosuppressive patients, that is patients who are on transplant or any other immunosuppressive drugs, and duration of hospital stay, that is the length of hospital stay is more prolonged, such as comorbid conditions, smoking, obesity, and higher wound classifications, which we'll be seeing in the further slide, and inadequate antimicrobial prophylaxis, improper surgical scrub, inadequate surgical scrub, or might be the skin antiseptics is not working properly, the potency is not maintained, or more increased operative time, that is, the surgery time is more than 6 hours or 10 hours. Shaving the skin, which is very unethical nowadays, we're only going in for clipping of the skin, and lack of infection control practices can lead to SSI. So the pathogenesis of the costoorganisms would be endogenous and exogenous. Endogenous is again what we told in the early cases, such as the patient's flora, such as skin, GI, and mucous membrane, and other area which is high prone to develop infection. And exogenous is that from the healthcare worker or any improper aseptic technique, inadequate hand hygiene, contaminated garments, equipment, surgical tools, environment can be the possible cause of exogenous. So surgical wound is classified as class 1, 2, 3 and 4. 1 is coming under clean, 2 is coming under clean contaminated, and 3 would be differentiated as contaminated, and 4 would be recommended as dirty infected. So this is according to the AORN, American Operative Classification of Surgical Wounds. So the common diagnosis, how we can diagnose is that we can take the wound culture and send it for wound pus for culture and sensitivity. So the 7S of SSI is safety, safe operating room, screening for risk factors such as methicillin-resistant Staphylococcus aureus and methicillin-sensitive Staphylococcus aureus, showering the patient with chlorhexidine before night as well as on the morning, and using skin prep by doing the chlorhexidine antiseptics, and surgical irrigation if necessary by using chlorhexidine, and sutures can be done by using antimicrobial coated sutures, and closing the skin is by using antimicrobial dressings. So surgical prevention bundle is like from 1 to 7 steps, starting from preoperative, intraoperative, and postoperative. So in preoperative, we use the on the prior to surgery, how we are going to clean the skin, how we are, in case if it is a colorectal cancers, how we are going to empty the bowel and fasting overnights, and whether if it is used for any antimicrobial enemas, all that we'll be planning in preoperative. And in intraoperative, if the patient is going for 1 hour prior to incision, we'll be giving the antibiotics, and if the surgery is more than 2 hours, might be the patient need a repeated dose of antibiotics. Intraoperative skin preparation by using chlorhexidines, and also using the suture with antibiotic being filled in the sutures, and throughout we are going to maintain the that is hypo and or hypothermia to be avoided, and normothermia to be maintained. Hyperglycemic control should be well maintained, and use of prophylactic antibiotics. And in the post-operative period, we are going to check in for the first 48 hours whether the patient is having proper care of the wound. So these are all we already discussed. So in intraoperative, what are the things to be maintained, and especially see that the surgical site preparation and throughout the procedure, the oxygen should be maintained, the temperature, the hydration level, the glucose level, everything should be maintained in normal level. And in the post-operative, daily dressing changes, removal of the discharges, as well as sterile wound dressing, and if necessary, the drain can be removed if it is minimal, that is less than 50 ml per day. And other extra things what we do in the OT is that permanent disinfection in the OT between the cases, that is might be on 9 o'clock you start the surgery and that first case is ending by 12 o'clock. Then the next case would be posted for 12:30, and between that gap, that is 30 minutes, we can ask the housekeeping personnel to do the floor mopping, and the equipment cleansing can be done by this floor nurse. And then periodic monitoring of the air quality. Engineering controls can be done in the OT to maintain the sterility. So to conclude, so it is all together as a team we can maintain the sterility and improve the patient's condition as well as prevent infection. And that's all for today. Thank you. See you in the next class.